Good afternoon. Welcome to this afternoon's webinar. And on behalf of the Association of Justice and Treatment Professionals and also the International Association of Treatment Court Professionals, welcome to today's webinar. A number of housekeeping matters. Panelists are reminded to keep their microphones muted when they are not speaking, and of course, unmuted when they're speaking. And also, we absolutely love to hear from you, to have get your questions. So there's a Q&A option. Please send us your question throughout the presentation. And at the end of the presentations, we'll certainly will address your questions. We look forward to receiving your questions. And I should tell you a few things about the Association of Justice and Treatment Professionals. That organization provides a forum for sharing effective justice and treatment collaborations that are aimed at combating the determinants of crime and rehabilitating individual, victim, and community. When it comes to the International Association of Treatment Court Professionals, that organization seeks to provide a forum for the exchange of ideas, standards, and practices for all types of treatment courts. You know, and sometimes treatment courts are called specialized courts, therapeutic courts, problem-solving courts. You could always find out what other webinar is coming up by following us on Twitter, LinkedIn, or you could subscribe at justicetreatment.org. A recorded version of this webinar will be available on the website, justicetreatment.org, usually available between 5 to 7 days after the webinar, so we'll endeavor to have a copy available. And the organizing committee. Joining me as host today, and my name is Justice Barnes. Jennifer Graham is the Assistant Crown Attorney in Peel. Andre Rivard is Duty Counsel, Legal Aid, Ontario. Kim Briggs is the Justice Services Case Manager at the Canadian Mental Health Association, Elgin County, and Kim Briggs will be handling a Q&A session today. Erin Smith is Counselor and Case Manager at the Peel Addiction Assessment and Referral Center. Jessica DiCuna is also a Counselor and Case Manager at the Peel Addiction Assessment and Referral Center. Now, at some point, I will introduce our panelists, but as more and more of us have gathered today, it's now appropriate at this moment in time to acknowledge where we are and to do the land acknowledgement. So at this time, Erin Smith will do the land acknowledgement.
Thank you, Your Honor. Good afternoon, everyone. So we would like to begin this webinar by acknowledging that we are meeting on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all the generations of people who have taken care of this land for thousands of years before us. Long before today, as we gather here, there have been Aboriginal peoples who have been the stewards of this land. In particular, we acknowledge the Anishinaabeg, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently, the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. We recognize and deeply appreciate their historic connection to this land. We also recognize the contributions of Métis, Inuit, and other Indigenous peoples that have made both in shaping and strengthening this community, in particular in our province and country as a whole. As settlers, this recognition of the contributions and historic importance of Indigenous peoples must also be clearly and overtly connected to our collective commitment to make the promise and the challenge of truth and reconciliation real in our communities. In particular, we would like to bring justice for the lives lost in residential schools, as well as all the murdered and missing Indigenous women and girls across our country. Thank you.
Thank you, Erin. Today, our webinar is going to last about a couple of hours, and we are going to talk about 3 different treatment philosophies. We'll talk about abstinence between whenever I stop talking and about 1:40. And then from 1:40 to 2:15, we'll talk about harm reduction. And then from 2:15 to 2:55, we'll talk about what a trauma-informed approach is all about. I shall introduce you to our distinguished panelists in a moment. But before I start, I just want to share a story with you. And it comes from a recent decision of the Ontario Court of Appeal in a case called Regina and Fabro, 2021 ONCA 494. Now, I do not refer to this case to talk about legal principles at all. It was when I was reading this case, I was struck by the story, because cases are about people. And it's about a Justin James Fabro who was charged with certain offenses. Now, he was 36 years old at the time, and he was in the throes of a heroin addiction. His domestic situation had broken down, and he wanted to end his life. His addiction started when he was overprescribed Percocet and Oxycontin at age 25. He had been prescribed 300 Percocet and 180 Oxycontin per month after a boating accident. He was at 25 years old. He had surgery on his shoulder and his knees, and he took pain medication for about 4 or 5 years. And when the doctors could no longer prescribe the medication, he began buying drugs on the street. He suffered serious unresolved trauma from 3 incidents. 1 year before the boating accident, he found the body of a neighbor who had committed suicide by hanging. Then he saw a friend decapitated in front of him. That was another incident. Then on a 3rd incident, he saw a snowmobiler go over a cliff. His resulting grief and trauma issues had not been addressed. In the month leading up to the incident, he went to a hospital for help on 3 occasions. He went to get help for suicidal ideation, but he was sent away each time. Just before 10 a.m. on the day of the incident, the police received information that the appellant had been seen leaving a residence with a gun and that he might harm himself. Shortly after receiving the call, the police located him. He was driving a truck. They initiated a traffic stop. He pulled into the driveway of a residence with which he had no connection, and he put a shotgun in his mouth. Police were on the scene. They called for backup. Emergency services arrived. More police officers and negotiator arrived on scene. He was emotional and upset. He didn't want to hurt the police or anyone else, only himself. He said he'd had a tough life, and using heroin he had been using heroin. He wanted to stop. He did not know what to do. He did not know how to stop. It is curious to wonder what type of treatment philosophy will work. Is it abstinence? Is it harm reduction? Is it a trauma-informed approach? Are all these 3 interconnected in some fashion? This is the background against which I introduce our panelists. Jennifer Berard is going to speak to us about abstinence, and she's a registered psychologist in the province of Alberta and the clinical lead of the Calgary Drug Treatment Court. She holds a Bachelor of Health Services with distinction in addictions counseling and Masters of Arts in Counseling Psychology. She has 20 years working the front lines of addiction and mental health in the areas of inpatient residential treatment, outpatient treatment, forensics, and private practice. In 2011, she was the first addictions counselor hired to provide service in the Calgary Remand Center. and found passion in supporting those who experience chronic addiction and involvement with the criminal justice system. During her tenure, Jen helped lead the development and implementation of the first treatment unit of its kind in the Calgary Remand Center that provided counseling, life skills, and employment resources to individuals while in custody and bridged these supports into the community. Jen has worked with the Calgary drug treatment team for more than 3 years and considers it a privilege to utilize her experience to serve this high-risk, high-needs population and contribute to both individual recovery and public safety. In addition to her work with the Calgary Drug Treatment Court, she's also the founder of the Jennifer Berard and Associates, a private therapy practice that specializes in substance use disorders, trauma, and operational stress injury in first responder populations. I am going to change the plan on all the panelists. Instead of introducing everybody else, because I've taken up a lot of your time, Jen, I'm just going to turn to you. Why don't you start up and use the time that you need? We'll adjust as we go along. So, Jen.
Yeah, that sounds great. Thank you very much. I'm just going to share my screen here. So thank you very much, Justice Barnes, and thank you everybody for allowing me to be a part of this webinar today. I'm here and I'm going to be talking to you about the abstinence model of treatment. One of the things though that myself and my co-presenters wanted to make sure that we talked about before we started was that we're not looking to sort of present these models as having to choose between one or the other, but more asking people to consider them as in terms of a continuum of treatment options that are offered to people who are struggling with substance use disorders. I'm going to talk a bit about one end of the spectrum, which is about abstinence, and then when I'm finished, I'm gonna sort of allow my co-presenters to talk about the other end of the spectrum, as well as how trauma is involved along the entire spectrum. So with that said, some of the things that I'm going to talk about in the next 30 minutes or so is just sort of a quick understanding of what addiction is, get into the philosophy of abstinence-based models, talk about the types of treatment that support these abstinence-based approaches, and identify both the strengths and barriers of this approach. As Justice Barnes mentioned, I am the clinical lead of the Calgary Drug Treatment Court, and I could probably spend 4 days talking about our program and the nuances of what we do and how we do intervention. We work with what we call a high-risk, high-needs population. So a majority of our population comes to us with severe and chronic substance use disorders, and also a lot of other needs such as homelessness, lack of employment, trauma histories, lots of things that kind of complicate treatment along the way. So I recognize that probably not everybody here works with that type of population, but it is the context with which I'm going to support some of the things that we're talking about today. Because the Calgary Drug Treatment Court is an abstinence-based model, I will be able to share with you how we both implement it, but then also how we address some of the barriers that come along with an abstinence-based approach. If you have any questions about it or you're interested in our program, please feel free to look on our website. There's a ton of information there about what we do and who we serve and how we do it. So before we talk about how to treat addiction, it's important to have sort of an understanding of what addiction is. Defining addiction in and of itself can be a very complicated and nuanced process, but the Centre for Addiction and Mental Health here in Canada provides a really simple way of being able to look at what addiction is and where the likelihood we would see the presence of addiction. And that's under what we would call the 4 C's. So when we see individuals who are experiencing craving, loss of control, a compulsion to use, and continuing to use despite consequences, if those 4 things are present, there's a very strong likelihood that they meet criteria for a substance use disorder in terms of looking at treatment options for them. When we look at abstinence in terms of a model, historically, and especially in North America, most addictions treatment, or at least a lot of the addictions treatment, has been centered upon this abstinence-based model. And this model asserts that in order to be able to treat and recover from addiction, that abstinence is an essential component of it. So not using drugs and alcohol needs to be sort of the essential component of it, and everything else sort of comes after that. However, I do want to recognize that particularly in more recent years, when we see the lethality of drugs that are coming out, as well as the opioid epidemic that we've been battling for many, many years now, that it's important to recognize that there are lots of spaces where we need to be able to look to reduce harm before people are ready and willing kind of to want to approach an abstinence-based model. And Carole is going to talk more about that today. But it is for that reason that it is essential that we have a continuum of treatment and not a kind of one or other approach to things. When we think about abstinence in its sort of general term, it is sort of exactly what it says. It is the trying of, or the choosing not to, or the not engaging in behaviors that people want to or people find enjoyable. Although a lot of our participants and a lot of people who struggle with substance use disorders would say it gets to a point where it's not that enjoyable anymore. But if there's one thing that you take away from today, or that you hear me saying, it's that in terms of addiction treatment, abstinence is not simply just stopping using. Stopping using is an essential component of this model, but it is only one component of this model. If we knew that simply abstaining from drugs and alcohol was the cure and the treatment for addiction, we would see people being able to find long-term recovery fairly easily. For example, when people go into detox facilities and they're there for 5 to 10 days and they come out, the drugs aren't in their system anymore, but we still see that those cravings, those compulsions to use, the relapsing type of behavior. We also see it in people who are coming out of treatment, and sometimes who have years well into recovery and being clean and sober from drugs and alcohol. And so with that really shows us that though it's essential, it's only one component, and simply abstaining from drugs and alcohol is not sufficient in treatment, and it's not sufficient in helping people achieve their goals of living sort of a clean, not clean, but a sober life. There are a couple of things that we look at in terms of sort of assessing whether or not somebody requires an abstinence-based type of approach to treatment. And one of them is sort of the severity of their addiction, and the other one is readiness for change. So if we talk about it in terms of severity for addiction, and we look across the continuum of use, we know that most people's process of use and over time moves through what we would call a sort of a continuum here. Most of us do it. Some people who develop substance use disorders get through this continuum very, very quickly, and some people get through it very, very slowly over time. We see people who move from no use. We see a lot of people in a vast majority of our population being able to experiment with drugs and alcohol, to use socially, and sometimes even starting to have some sort of serious social components to it. Usually though, within this aspect of it, we can see people being able to still have control over their use. There's not a lot of cravings. When they start to have consequences, they're either able to stop or change or moderate or reduce in that aspect. And so when we're talking about people who need or choose abstinence in terms of their treatment philosophy, we really are often looking to people who are a little bit further down this scale. So people who are starting to have consequences in their major life areas, where things are becoming increasingly problematic for them, in their family, with crime, with mental health, emotional health, physical health. We can see people moving into dependency, where they are having withdrawal symptoms when they stop using, and they need additional intervention to help them to be able to get through that. So when we're talking about an abstinence model, really what we're looking to serve, and where we see people really choosing and wanting to abstain and get treatment and intervention for it, is usually people who are on the other end of this continuum. Through my experience, through my over the last 20 years, and with a majority of people that I have worked with who are at the sort of higher end of this continuum of use, oftentimes we'll try to reduce and we'll try to moderate, and we'll will try to kind of take control over what they're doing. And oftentimes I find that in that process, which is a very natural process of coming to change, recognize very quickly that because of those 4 C's that we were talking about, compulsions, cravings, control, all of those sorts of aspects, find it increasingly difficult to maintain a healthy life while they're continuing to use or drink, and often get to a point where they will say that the option for them and the best option for them moving forward is to abstain and go into a period of no use. The other thing that we look to do is we look at readiness for change. So one way of looking at this is Francesca and DiClemente's theoretical model of change, which really we can apply to any major life changes or health changes that we do over time. But it works particularly well when we're looking at trying to connect individuals to treatment and intervention that, that best meets their needs. And so in a nutshell, when we kind of look at this, when we're looking at pre-contemplation, what we're talking about is individuals who, for a multitude of reasons and for really complex reasons and barriers and circumstances, aren't even contemplating change. They're not thinking about stopping, they're not thinking about reducing, but a lot of times we can see people still in very active addiction and having consequences when they're in this phase. Contemplation, we see people starting to move and sort of weigh the pros and cons of change and wondering if they want to or what that's going to look like for them. And from there, as people start to decide for themselves that treatment is essential, or that they're looking for abstinence-based type of approach to their healing and their recovery, will start to make plans, they'll start to prepare, they'll go into action, and sometimes that looks like getting into treatment or doing things that will help them support stopping using. And then also in the maintenance phase. We do also know that addiction is a chronic and relapsing disease. And so oftentimes, and for many people at various points in their readiness for change, will relapse and will find themselves sort of back to different areas of this. So again, in terms of abstinence, where this model works really well and where people can really engage in it and develop sort of abstinence-based goals around their drug and alcohol use is when we see people sort of in that late contemplation stage, but really moving into preparation, action, and maintenance. And so that's kind of the spot where when people are demonstrating that as part of their goals, and when those are the things that they're wanting to do, that we would usually look to provide that kind of intervention. The one area, and I'll address this again in the barriers though, but while we're here, I think is important to note, is that one of the phases of this that abstinence misses is people who are in contemplation or are in pre-contemplation, and they need services and they need to be able to have dignity of life, and they need to be able to reduce harm. And hopefully, the hope from an abstinence place is that people will stay, will reduce harm enough that when they are ready, that they're still alive and willing and able to go move into sort of other abstinence-based goals. And then we're ready for them when they come. And so the abstinence-based model works well across a lot of this, but the population that it really misses is those who are unable, again, for a lot of complex reasons, to not make the change that an abstinence model would require. According to the National Institute on Drug Abuse, addiction treatment has to do a few of the following things. So you would, if you recall, just stopping is not enough. It's not what we would consider sufficient under an abstinence-based model. There are other things and other interventions that we need to be able to supply and apply to our clients. So the first one is to stop using drugs. As we talked about earlier, that's an essential component of an abstinence-based model. But we also have to help people stay drug-free and become more productive and more engaged in aspects of their life in a more healthy and fulfilling way. And so that can look like various things: family, work, society in general. In the Calgary Drug Treatment Court, we have our participants work with us for a long time. They're with us from a period of a minimum of 12 months, sometimes up to 24. But I'd say the average amount of time that we work and intervene and provide treatment for our participants is around that 15-month mark. So if we look at this in terms of how we apply this model, is the early stages when people come into our program is where we are looking at helping them stop using. So we connect them to detox facilities, we connect them to intensive residential treatment programs if that's what they need. And we can see people in that early phase of being in treatment from anywhere from 6 weeks to 6 months, depending on the individual's needs and the treatment options available. But all the time that they spend with us after that is looking at these other goals that we need to be able to offer in terms of treatment for people to be able to sustain and maintain these goals that they have around abstinence. So we are really looking to help people stay drug-free, and we're really looking to help and support them in some of their needs in terms of being able to work, reconnect with pro-social people and family if they have them. And a big one that we really look at is this component of being part of the community or in society. So particularly where addiction is concerned, as it's so stigmatizing, but then also when you add in the layer of crime and criminal justice involvement, I guess is the way to say that, is that we see people, our participants will often say that they don't really feel like they're part of the community. And I think the community would also say that they don't feel that they're really part of the community either because of the public safety issues that come along when they're active in their addiction. And so we really look over the course of our entire program to help people not just stop using and stay stopped using, but to find ways to plug them back in and connect them into various communities and into our community, not just so that they're giving back to our community in ways of reparation for things maybe that they've done, which is more of a punitive way of thinking about it, but more that we know that that we sustain change better when we feel like we're part of something. And so that's a really important component about what we do and why it's important to take treatment sort of beyond just stopping using. Other aspects that need to be looked at are modifying and challenging and exploring changes in attitudes and behaviors related to drug use. And for those that are in the criminal justice system, I would also say that we have to do that as well in terms of their criminogenic thinking. We want to be able to help them increase their healthy life skills. And in the next slide, I'm going to talk about different varying treatment options, but we have to be able to help them persist with other forms of treatment beyond just not using, and recognize that there's different ways and different settings that in which we can connect them to. The other thing that the National Institute of Drug Abuse talks about that I think is particularly important when we're talking about clients within the criminal justice system is that individuals who have criminogenic backgrounds or criminal justice backgrounds often need additional types of service in order to efficiently and effectively treat their substance use disorders. And so to give you sort of context of that and what that means using our participants in the drug treatment court is that we have the cycle of addiction and those 4 C's that we see happening that people are trying to stop and that we're trying to help stabilize. But also our participants that come in who have lengthy involvement with criminal lifestyles or within the criminal justice system will also identify that lifestyle in and of itself as an addiction, something that they have cravings for, that they have compulsions to do, that they can't stop once they start. And we will often talk about, and they will often tell us, and we see it through experience, that if we don't treat both of those things, if we don't help them develop skills and resiliencies in both of those things, that when somebody relapses on drugs and alcohol, they very quickly end up back into their criminal lifestyle. And if people relapse into criminal lifestyle type of behaviors, it often very quickly leaves them back to drugs and alcohol. And so in our program, we offer evidence-based cognitive behavioral approaches that help our individuals and our participants to look at sort of criminal addictive behaviors and try and sort of interweave both of those through it. Because if we don't address one, then we don't address the other. And again, people become increasingly at risk of relapse and not being able to sustain their goals of abstinence. Oftentimes, at least for me, I can say, when we think about abstinence-based treatment, sort of the first things that pop up in our head that are pretty obvious that support abstinence-based goals are residential treatment facilities, detoxes, community support groups like a 12-step and smart recovery. And those are really great options for treatment that support abstinence-based goals. But it's also important to remember that there are other things that we need to connect people to in order to help them to be able to continue on and to sustain that. And so some of that might look like addressing co-occurring disorders. That could be other mental health issues. It could also be chronic pain. There's lots of other things that could be happening simultaneously for individuals that, if left unattended to, put their abstinence and their recovery from drugs and alcohol at risk. We know that it's chronic and relapsing, and that at times people need various interventions. So people who are on the more severe end of the spectrum need a lot of times long-term follow-up and relapse prevention, which we're able to provide at the Calgary Drug Treatment Court. We also need to support people in medications, mental health, trauma therapy, connect them with therapeutic communities like sober housing. Behavioral therapies like CBT and DBT can all be used as interventions to help support goals that are around abstinence. So again, it's about thinking about this in terms of a continuum and not simply going to a treatment facility and stopping using, and then that's the end of the process. There's many, many things that we can do in order to be able to help people along the way achieve these goals that they have for themselves. Now, not every model is perfect, and I can certainly say that there are lots of reasons why we need this continuum of intervention, but particularly where the abstinence model creates barriers are in the following ways. So, as I mentioned earlier, it doesn't sufficiently support individuals who are at the beginning phases of readiness for change. And I really don't want anybody to hear me saying that people who are pre-contemplative are not ready, that they're not ready because of willpower or unwillingness or any of that kind of stuff. There's a lot of really complicating factors and barriers that make abstinence a hard option for people. And so in that aspect, we see people can kind of get missed along the way, and we really need to have interventions that are in place there for them, which are life-saving interventions. When we think about it in terms of a continuum, so for a very long time, and I think it still continues a lot, is that the abstinence-based model and harm reduction models kind of get pivoted against each other. You either have to choose one or the other, or it's all one way or it's all the other way. But when we think about it in terms of a continuum and sometimes being able to blend aspects of it, that's where we see these, at least from my perspective in the abstinence place, that's where we can see things really sort of amplify meeting the needs for our clients. When we think about sort of old school, really fundamental and rigid abstinence-based type of thinking, at the very, very end of that continuum, when we apply it too rigidly, it can create significant barriers for people in their treatment and their recovery. So, for example, there are some people who believe in the fundamental aspect of abstinence, which says that if you have to put anything into your body in order to not use drugs and alcohol, you're not in recovery, it doesn't count. If you're taking medications that support you in not using opiates, that doesn't count. So those would be things like Suboxone and methadone. If you're taking medications that make you feel better and less depressed so that you don't use or drink, that doesn't count. And we find that, at least I find that to be really rigid, and it creates a stigmatization where people are either afraid to access potential life-saving medications and interventions, or are unable to access treatment because of the barriers that creates. We still have a lot of treatment centers out there that won't accept people who are on Suboxone and methadone. We have a lot of treatment, well, I wouldn't say a lot, but we still have treatment centers that have medications that they won't accept, psychiatric types of medications. And so how we address this, a barrier in the Calgary Drug Treatment Court, is that we fully accept and we believe that addiction is a chronic and a relapsing disease. We believe that it is something that needs lots of aspects of treatment to it. We look to our medical professionals to provide information and prescribe necessary medications in order to support abstinence-based goals of not using illicit drugs and alcohol. And in the event that we have people in our program who are on types of medications that really have a lot of barriers in terms of getting them into residential treatment, we will do whatever we can to come up with individualized plans to be able to support them in recovery goals and abstinence-based goals, but we don't turn people away because of their medications. The other thing that can happen when applied very rigidly, and we see this happen in a lot of treatment centers, is that when people do relapse, as they do, it happens in addiction, and it happens a lot over recovery, is that people get discharged from programs because of relapse or because of slips or because of use. And when we think about it in terms of programs and addictions treatment centers, one of the main reasons that they do that is because a lot of people will say that their biggest triggers, particularly in early days, are being around people that use paraphernalia, people who are intoxicated, places where drugs are around. Those are highly triggering environments for them. So the decision to discharge individuals is sort of for the sake of the sober environment and for the other people that are there. And that makes sense in some aspects, but for the individual being discharged, it actually creates a missed opportunity. It's a missed opportunity for them to be able to have access to the treatment that they've already started. And it's also a missed opportunity for them to be able to change within a supportive environment. So again, how we address this barrier at the Calgary Drug Treatment Court that probably moves us a little bit more into the middle of the continuum as far as abstinence is concerned, is that we don't discharge for relapse, and we don't even sanction for relapse. We consider it part of the process. And as I said earlier, our participants identify that if they relapse very, very quickly, they end up back into their more kind of criminal behavior and the problems that brought them into the justice system. So what we look to do when somebody relapses is we look to treat them. We look to assess, we look to find out what they need, and we connect them to whatever appropriate treatment support they need at that time. Sometimes it's detox, sometimes it's residential treatment, and sometimes it's a little bit more outpatient counseling or support that's needed depending on what happens there. So from our aspect, we don't discharge for relapse, but we do have some goals around abstinence. For example, we require people to have 90 days free of drugs and alcohol prior to their graduation at the end. And a big part of that is so that we're setting them free and graduating them out into the community at a place where they're more stable and we're not kind of letting them go when they're in the middle of crisis. Again, it can be perceived as stigmatizing. The other thing that's really hard to do with the abstinence-based model is that we need community service providers and partnerships to help us do this. And so again, with our program, we know that we have the privilege of having a recovery community here in Calgary that works with us. We have treatment centers, we have sober living housing, we have employment programs, we have a whole slew of community partners that work with us that make abstinence-based goals and recovery and intervention possible for our participants. Fully appreciating that if you're in a situation where housing is not an option, where there are no safe housing options, maybe you're in a remote area where you are the only intervention that is possible, that all of those things make being able to sort of provide a full and comprehensive abstinence-based approach increasingly difficult. And the last thing I would talk about is continuity of care. And so I don't know about everybody else there, but I know that one of the biggest struggles in treating addiction is wait lists. There's wait lists for everything, particularly for treatment centers. So in order for the abstinence model to work perfectly or at its best, is that we would want to see no gaps between the different stages of care. So if someone goes into detox, that it would go from door to door into treatment, and then it would go door to door into sort of whatever things come after that. But we just simply know that that's not the case, that someone can get into detox and then it's a 6 to 8 week wait list for treatment. And then after that, it might be another couple of months before they can access other sober housing facilities or supports that are in the community. And so each and every time we have a gap and a break in that continuity of care, there is high risk for relapse, and we know when people are relapsing and using that it increases the chances of outcomes such as death and other consequences. So at the Calgary Drug Treatment Court, we probably spend a good half of our time really working on trying to shorten those gaps through advocation for creating treatment plans, for planning down the road and getting a whole bunch of things set in place for our participants, because we know continuity of care is important. However, with all of our service providers and all of our avocation and all of our networks, it's still really, really hard to do. So when we look at individuals who are trying to set up their own treatment plans and get into treatment and to find abstinence and recovery, it's a really hard thing to do if we can't manage to be able to provide people with continuity of care. However, with that said, there are a lot of strengths to this approach as well. Over my entire career, I've seen people from all aspects and walks of life make extraordinary changes in their life. I've seen this model when it works for people to be empowering. It provides individuals with hope that a life free of drugs and alcohol and the chaos that comes with it is actually achievable. It provides people with skill and resilience. It allows us to provide a time where we can help people stabilize their addiction and maybe get into more and address more underlying core issues such as mental health and trauma. It creates space for safe environments for people. It helps individuals achieve other important life goals. So within our program, we often see people as a result of the fact that they are choosing and maintaining and being treated from an abstinence-based approach. Child and Family Services starts to be able to give them regain access to their children. We see them stop engaging in that revolving door criminal justice system that they can be in. So it has rippling effects kind of outwards and beyond sort of just the addiction component of it. But really at the end of the day, when this works and when it works well for people and when they find success and when they find recovery, we get to see the positive impacts that it has on their emotional, their physical, their spiritual, and their social health. And so recognizing that there's barriers in it, there's also a lot of strength and a lot of empowerment when it does work and when it works well and matches up well with individuals. So I am aware, I think that puts me right at my time. I could probably talk about this stuff for days and days. I'm very passionate about the whole continuum of treatment. So I just really want to say thank you for listening to me today. And hopefully there was some component of that you found helpful and beneficial. Thank you very much.
Jen, thank you very much. Most informative, and I expect that there'll be some questions soon. But thank you. The passion was quite clear, and I learned a lot. So thank you very much, Jen. Thank you.
Thank you. It was my pleasure. Thank you for having me.
Yes, but stick around, because there may be some questions. Yeah. All right. Okay. So Carole Sinclair. Now, Carole is going to talk to us about harm reduction. Carole is a social worker and a clinical manager with 10+ years of history of working in the hospital, healthcare, and social services sector in community-based outpatient and inpatient milieus. Carole's population focus is individuals who are street-involved, living with concurrent mental health, trauma, and substance abuse. Carole's current position is Manager of Harm Reduction Services at Somerset West Community Health Center in Ottawa, Ontario, where she manages a range of harm reduction services, including needle exchange, supervised injection service, addiction medicine / safe supply, drop-in, and outreach services, supporting interdisciplinary teams comprising of harm reduction workers, registered nurses, nurse practitioners, and community workers, which are peer positions dedicated to people with lived or living experience and expertise of substance use. The services operate at the intersection of community and medical models of care with a strong focus on peer engagement and inclusion of people with lived or living experience / expertise in all areas of the team. And before Carole speaks, I should just remind you of a couple of things. Use the Q&A if you want to engage with us. We are unable to respond to you when you use a hand, so do not raise your hand. The Q&A, we are looking forward to talking to you. and we're going to keep going. So feel free to, walk away from your computer, stretch, do whatever you need to do to stay in shape and not feel stiff. Carole, over to you.
Thank you, Justice Barnes, and good afternoon. Nothing like hearing your own bio to realize it's way too long. So thank you for that introduction. I will set up my screen share here. So yeah, thanks for this opportunity. Just a few acknowledgements at the front end. I have been working in harm reduction now at Somerset West for 3.5 years. I want to acknowledge as well here that we do the work on the unceded, unsurrendered land of the Algonquin Anishinaabe, and that we seek to honor that in meaningful ways through the partnership and leadership of Indigenous knowledge keepers who work with our harm reduction program. We know there's such a significant intersection of trauma, residential school surviving, and substance use in some cases for folks who are in that Indigenous community. And we acknowledge what a difficult time it is now for that community. With that being said, I want to acknowledge that I myself am a white settler. I am not a person with lived experience of substance use. And so it's really important for me to name that up front, because all of the deep wisdoms and truth that I hold about this work come from people who use drugs, who I work alongside with, and who I design services for in that effort to be an ally. I want to thank, all of the service users and staff I've worked with have really taught me so much. And I want to specifically thank Jay, Ryan, Aaron, and Andre today, who are individuals who specifically gave me some input into the content of the presentation, and so many more, so many more. So that being said, I'll talk a little bit more about the programs we provide at Somerset West. I think that harm reduction certainly is a long-standing, in many ways, form of service delivery. It really is something that has come out of the drug-using community. And it's something I think folks will find it really dovetails quite well with what Jen was describing. Harm reduction are services that evolve to fill the gaps, right? And we'll talk about that a bit more later. There's lots happening in harm reduction right now. Certainly, and unfortunately, the overdose crisis is an impetus to that. So some services have been happening for a long time, either in formal ways or in informal ways amongst the drug using community. And we see them becoming more and more formalized now, receiving different sources of funding and being embedded into environments that are more and more institutional and formal. Like my own here, where we are a community health center. So we provide needle exchange and safer inhalation gear exchange. So that's providing the tools to use drugs safely. So that's like syringes and pipes to smoke drugs, that kind of thing. I want to acknowledge that harm reduction supports all people who use drugs. It can support people across the drug using continuum. Not necessarily people who have who struggle with substance use that is a dependence for them or problematic. At the same time, my work right now focuses more on with folks who are street involved and justice involved. And certainly when people do become justice involved, that can be a sign that their substance use is causing challenges for them, to Jen's point around some of the consequences that people experience at the same time as their substance use. So I'll just acknowledge that that's the focus for the discussion that I'll be leading today. We have supervised consumption services, which are also called consumption and treatment services here in Ontario. And those are services where people bring their pre-obtained substances. They come into a safe and hygienic environment that is also ideally comfortable for them, and they can consume their substances in the presence of healthcare workers and peer workers and harm reduction workers who can then respond to that overdose and also meet many of their physical health care needs like wound care. we have different outreach-based programs, and I won't go through each one of these exhaustively, but we have different outreach-based programs that operate daytime and nighttime foot outreach and using an outreach van, providing those supplies that I mentioned before for safe substance use, as well as providing contact information, referral, and connection for folks into the broader health and social service system, because for some folks, using drugs can be quite isolating. Because of our drug laws, folks who use these substances are by definition engaging in a criminal activity, at least right now. And so there are very real implications for what that means in terms of people's stigma and access to services. We provide addiction medicine. So Jen talked about the medications that can support people's stability. And when I say that harm reduction intersects with community development, health and social services, and medical services, this is a great example. So there are treatments that are called opioid agonist treatments that are medications like methadone or Suboxone that people can use to, in some cases, either like replace some or all of their substance use. And OAT happens across the treatment spectrum, to Jen's point. We also have emerging practices like safe supply. Safe supply is something that is currently being piloted in much of the country through Health Canada funded projects and other initiatives. And we spoke a little bit earlier, actually in Justice Barnes' example, we know historically there was a time where there was a lot of overprescribing of opioids, and that this led to a degree of opioid addiction in our society. There was a right sizing of that, certainly, and then that prescribing really dropped off. But what we also know is there are some folks who are at one end of the acuity spectrum, who are folks who are often street involved, who have had multiple attempts of treatment programs, be they psychosocial rehab or opioid agonist treatment, where there are folks who are so heavily reliant on the street supply, whose tolerance is so high that for them, moving them back onto a prescribed supply is life-saving. And so it's quite controversial, and I think sometimes people think that safe supply means we're applying it across the board. And it's important to understand it's something that's clinically indicated for a portion of the substance using population, and done so, the prescribing is done so under close supervision and examination and monitoring. We have homeless outreach as well. We see, especially during COVID, we've seen an increase in street involved folks living in distress. People are not having access indoors to the services they need, even having respite from like the elements. And so certainly, as many folks here have probably seen through their work, we see the increase of physical impacts like wounds and heat exhaustion. We see increase in substance use because people are outside on the street longer, trying to stay awake, to stay safe. They might be using more stimulants. They might be coping with more distress. And of course, then that mental health and psychiatric distress can lead people to have more crises. The last thing I'll name that we do, which I just think is so interesting to share, is that in Ottawa, we have a partnership with the City of Ottawa, and we've launched in COVID respite centers that are a differently scaled type of drop-in space, and we've embedded harm reduction workers in those spaces, recognizing that often the needs of people who use drugs are overlooked in different spaces. And different service types. And so harm reduction really seeks to embed that comfort and competency in supporting people who use drugs, whether they're intoxicated or not, so that these folks can access the range of social services available to them, decreasing that isolation. So I'm going to go over 3 broad themes for harm reduction. And then cap it off, because there's always so much to talk about. So first, I think, what are some takeaways Harm reduction is a life-saving intervention. It's something that prevents the transmission of infection. So things like HIV, hepatitis, making sure people have access to safe substance use supplies is critical for their well-being, and for their recovery, whatever that may mean to them, and for the well-being of our society as well, and our public health collectively. You know, to complement Jen's point, harm reduction is something that can support folks at any point in their recovery continuum, right? If we're being pragmatic and we want to see people succeed and progress in their goals and build on those gains they've made, that if people do have a relapse, which we all do when we're undertaking to make change, we all have times where we're trying to do something that's new and we fall back sometimes, or don't make the choice we wish we made sometimes. It's important that people have ways to do that safely. Early health interventions are really important with harm reduction. There's an example I love to share. When our injection site opened, you know, we had folks who, you know, who to be able to maintain their health and well-being, they based on their substance tolerance, you know, they're injecting multiple times a day. In some ways, people were really housebound because of that. You know, withdrawal is terrible. Withdrawal is a terrible, terrible feeling, and can be incapacitating physically. And I think it's important to understand that. It's a very real barrier for folks who have high substance dependent to opioids in particular. And we opened the injection site, and, you know, I remember one of our longtime outreach workers standing there telling me, seeing a client in the space saying, you know, I used to look for weeks for this person, and usually by the time I would find them, they would be going septic from infection, and we would be trying to do like move hell and high water to get them to the hospital, you know, and they would be put on IV antibiotics. And they said, now I see them every day and I've never seen them look healthier. So when we have services that are designed to meet people where they're at, designed to be effective and relevant and safe for people who use drugs, it means that they can access that healthcare, access that wound care, access that health testing and early intervention. And that's not just important first and foremost for their health and longevity. It's tremendously pragmatic and makes sense for us as a healthcare system, right? We know that early intervention is important on so many levels in the healthcare system. Overdose prevention is so important and just can't be said enough. There's a common refrain folks might have heard: you can't work on recovery if you're dead, you know. And we say it so much it feels like we're a little flippant. But it's absolutely true, you know, it's absolutely true. And a little later, when I think we talk about some of the transformation that people have experienced, you know, I hope we keep that in mind, that preventing overdose and keeping people alive is just tremendously important. And harm reduction services play a huge role in that, as do many services do. But it can't be said enough that harm reduction saves lives. It is compatible with recovery models, and it supports and sustains recovery. So that speaks to my point earlier that we're humans, and recovery and change is not linear. Usually it's cyclical and iterative. And harm reduction is there to make sure that when people I don't know what to call it, but when they take a step or have a turn in their life that doesn't fit with the recovery program or model that they're in, it's important that people have a safety net. It's important people have an option to continue supporting them, so they can continue their recovery in whatever way works for them at that time. I've already said it's pragmatic. I think it's really important to name, don't let the perfect get in the way of the good. So there's lots of people where abstinence is the right option for them. There are many people, and I have many clients who don't have abstinence goals or who do have abstinence goals. It's really individual. But if we wait around for all the factors to be put into place so people can have success in what might be their ideal framework, if it's a recovery framework, we're going to be waiting a long time. And I think the overdose epidemic speaks to that. There are people who are at all kinds of different places and ranges and stages of their wellness with substance use. And it's paramount that we provide equally a range of services that addresses the spectrum of needs and acuity. And what harm reduction does to an extent is it's broadening that range of services so that we don't have a whole portion of this healthcare population who's just left out in the cold, you know. So I mentioned I was able to get some great input from folks. I was speaking with one person today, and all the folks I spoke to today have experience with treatment programs. They have experience with the justice system. They have experience with harm reduction. And one gentleman said, I'd rather leave jail and run to my safe supply or an injection site than go to my dealer and overdose. And I think that's pragmatism at its core. Regardless of our best hopes, maybe we wish someone could leave incarceration and be picked up and driven right into detox and then right into the treatment center. If that's their goal, that's not the reality. And we need to have pragmatic interventions that keep people sustained every step of the way. Harm reduction is accessible. So I've already been talking about the way that this bridges the acuity gap. Harm reduction is intentionally very low barrier, recognizing that there are folks whose acuity of substance use means that they can't make appointments right now. It means they might not be able to attend an appointment without having used substances first. It acknowledges that the other things that people are coping with, be it trauma, which we'll talk about a little later, be it other stressors in their lives, it acknowledges and it sort of challenges some of the old thinking around, you know, we can't work harder than the client does, or people have to be ready. That's true. At the same time, if we are taking the responsibility to use our publicly funded dollars to create services that meaningfully engage people where they're at and meaningfully produce outcomes, we need to be designing services that are accessible. And we do that in other sectors, but for some reasons, when we think about services for people with mental health or substance use, we have a bit of a mental block. And I think as a sector, we need to get better and better at that. And we are. So these services are intentionally very low barrier. In many cases, harm reduction services are anonymous, recognizing the criminalization and the stigma and the impacts in our society of being someone who uses drugs. Harm reduction services create opportunities for folks to get connected into that treatment system in whatever way is safe and healthy for them. Because of that, we do need to keep in mind that many of our folks who use substances experience a lot of social and institutional exclusion. And so there's lots of literature that speaks to the challenges of people who use drugs in accessing emergency departments, for example, and having their pain needs or withdrawal needs met in hospital. So there are, or in jail, we know that there are some cases in incarceration where people's methadone or Suboxone or safe supply are not able to be continued. And so it's worth naming, not to disparage these different institutions, but to acknowledge that as a society and a system, we still have lots of work to do in terms of building those systems and really supporting people who use drugs every step of the way so that they can engage with those systems in a way that's safe for them. It's also worth noting that because our folks are often not comfortable interacting with the justice system because they're engaging in, by definition, criminal behavior, there's lots of times when harm reduction services might be the only institution they're engaging with, including for their justice needs. So we have folks who are trying to meet a lot of their needs on their own. People talk about street justice. It's often spoken about in quite a disparaging way, but when we think about the experiences of people who use drugs, who perhaps many years, perhaps lifelong, perhaps for generations, they are part of a subculture who does not feel like justice is for them. That if they get robbed or if they get beaten, it's not safe or comfortable for them to bring that forward, because they're also a criminalized person, and they they have anxiety about how will they as a drug user be seen and understood. Programs like Drug Treatment Court and many other programs and partnerships have brought that forward a tremendous amount. But there's history there that we have to understand leads to that disconnect of this population with mainstream health and treatment services many times. So when I say culturally appropriate, that's what comes to mind. I want to speak about it being peer-based. So we have peer workers who are full employees as part of all of our services in harm reduction. And we also strive to be representational and prioritize hiring people with lived or living experience to all our positions. Embedding people who have lived or living ongoing experience of drug use in our staff team has been absolutely transformational. It's been the most impactful thing to me in my work life. It really, I cannot say enough about how important it is to have those folks in these services so that we can tailor services to meet the needs of the community. And good health services are always trying to tailor ourselves to the needs of the community. Our peer-based services, and we have a whole outreach team that is peer-based, are able to connect with folks, gain access into homes and spaces, learn the needs of individuals to a depth that that service providers without that lived experience or without that peer identity, I think, just can't access. And the number of times we've been able to provide truly meaningful interventions to folks, because those folks have been able to communicate their true, genuine healthcare needs to those peer workers without stigma, without judgment, without fear of consequence, is really transformational. I'm just going to check. I think I'm doing okay on time. Another quote from one of the folks I spoke to today. This is a paraphrase. Forced treatment has never worked. It's usually someone else, like family or friends, pressuring you. It's a lot of work, and it won't work if you don't want it. You have to be ready. I want to talk about health equity as a final concept, and it, of course, dovetails with accessibility. I think it's worth restating that we have individuals in our society who have a real deficit in their social determinants of health. So to Jen's point, there are criteria, and they are reasonable criteria. I've worked in the addictions treatment sector too. There are some criteria that are there for people to enter a residential facility or an inpatient environment. And there are some times where we have folks who just don't have the stability to be able to enter those spaces, So people are living with unstable housing. People do not always have the social supports and family supports. To take on treatment and therapy requires a level of internal resources and external resources. And to engage in that without the supports around you and ready for you throughout and after that treatment can be quite destabilizing. One of the concepts that can come up in treatment sometimes is to remove triggers, right? To change your environment. And when we have people who are in social housing and they've been on a social housing list for 5-10 years, I used to be in Toronto, it's probably up to 15 years now in Toronto. But when you have people who've been waiting for social housing for years, they don't have an option to change their environment when they come out of that treatment. for some folks, when we think about social capital and social safety net, their network of friends and loved ones are all also people who use drugs. So we, harm reduction is a health equity intervention that right sizes and the accessibility of health services to individuals, regardless of the context they're living in, which might include poverty of social determinants of health. I think the health equity piece really speaks to that model intersectionality. We are doing community-based interventions and supporting community development for a community which, as I mentioned with the accessibility points, in many ways is self-contained and isolated from broader society in some respects. And so, harm reduction is a health equity intervention because we're knitting together wraparound services to bring people into healthcare, build that trust and relationship, and then branch them out further into other supports. I've spoken about deinstitutionalization already. I think it's worth noting it's anti-oppressive and anti-racist. We know that people who use drugs often have a high intersection with other identities and experiences of oppression and racism. Social reintegration and repatriation, I gave that example before of the individual who went from seeing an outreach worker once every few weeks or months to being at a health center daily. I think it's so important that that act of re-engaging with society exists through all avenues. It exists through treatment programs. It also exists through community-based harm reduction programs where people are able to enter into that community and that programming and engage in volunteer work, engage in peer-based support, engage in employment as a peer worker, as an employee. So we have a number of folks, because harm reduction services facilitate the presence of people who use drugs in society because of injection sites, because of drop-ins that are inclusive of people who use drugs and intoxication and outreach services. We see that folks who are still quite marginalized, but also often relegated to aside spaces, are now returning into society, and they're seeking that commitment and that interaction with community as well. So it's a person and community approach, because we know that there are, to Jen's point, in the network of services, people are not necessarily going to be able to change their whole lives and change their whole community and their environment. And so harm reduction is important, because how do we help people find recovery and meaning and health in their environment, in the midst of the challenges and barriers and communities that they may live within. One of the folks I talked to today talked to me about a Globe and Mail article he had read recently on decriminalization, and he felt it was important that I share it with you all. There's a Globe and Mail opinion series. And I think, this headline felt really important, that we've lost over 20,000 Canadians since 2016. So to Jen's point, it's I think we've moved beyond questions about philosophy of care. I think we've moved into understanding of support and treatment spectrum. And we know that the more limited options haven't been working because they didn't work for those 20,000 lives and more that are gone. So these harm reduction services are always evolving so that we can really have support and treatment for everyone. A little bit about the way forward. Again, I want to acknowledge that the history of harm reduction and the continued evolution of harm reduction is driven by people who use drugs, who have had to advocate for their needs because they have not always been well represented in the health and treatment sector. So nothing about us without us is important, that I name as a non-drug user doing this presentation. I want to talk a bit more about peer-based services and community recovery, because we talk about recovery, and I think we're also broadening our understanding of what recovery means through harm reduction interventions. So, you know, I think a lot about what does accessible employment mean. So, you know, I have employees right now who started out as users of our gear exchange, our drop-in, or our supervised injection site, who are now full-time workers or part-time workers at our health center, making like tremendous contributions to their community. And some of these folks are people who still use drugs, right? So for some people, abstinence to be able to engage in employment and community contribution is important. It's not the only way anymore as we broaden our understanding of what supportive employment and supportive community looks like. So think about how meaningful that is for our service users who see people they've known for decades, their friends and loved ones in the community, who are now healthcare workers and helping respond to that overdose and helping accompany them to a health appointment. It's really transformational. And I think we have folks who are then even more so engaged in the safety and well-being of their community. You know, I have staff who haven't incurred any charges or contact with the justice system for years because now they have employment. You know, I think I have to name a bit more about decriminalization in that context, because we really, I think, in the harm reduction sector, although not everyone in harm reduction necessarily espouses decriminalization, right? There's just as much diversity in that sector, but there's a lot of discussion around moving from a justice lens to a health lens. So what is the right space and place to support people who use drugs? And you know, what does it mean that we've built a whole intervention type and service sector to try to reach people who've been criminalized for the way that they're coping with their trauma, mental health, or other challenges? From a fiscal standpoint, having a healthcare approach makes sense. From a compassion standpoint, from a stigma standpoint, for people to understand that they're using substances to cope and survive, but that doesn't make them bad or wrong or illegal, I think is such a crucial step forward in truly bringing healing to our society, to people who use drugs, and to their families and loved ones. And so what does that mean when we think about a society of how are we supporting trauma survivors? Because really folks who are using drugs to the extent that it's causing problems with justice, often it's because they're trauma survivors and they've been in institutions in the past, like Children's Aid or residential school, or other institutions, and they have or other types of trauma, and they've survived that, and they're still trying to cope and need support. And so I'll pause there. I'm sure I must be at my time, and I know Robin will take us further talking about that trauma-informed care. Thank you.
Carole, thank you very much. Also very, very informative. I learned a lot. Thank you. And we'll have some questions for you, I expect, at the end. So Robin, it's now about trauma-informed approach. And Robin is the manager of a variety of specialty concurrent disorder treatment programs at the Center for Addiction and Mental Health, including the Toronto Drug Treatment Court program. Previously, Robin has led agencies providing women's residential addiction treatment, withdrawal management, services for substance-involved women and their children, and a program for pregnant and parenting teenagers and their children. Robin is a registered psychotherapist. She's a faculty member of the William Glasser Institute for Choice Theory, Reality Therapy, and Lead Management, and has extensive training in addictions, concurrent disorders, and trauma-informed care. Robin has a strong commitment to creating client-centered, trauma-informed services and team cultures, and is particularly passionate about working with people who have been marginalized on a systemic level. With a knowledge exchange lens, she has contributed to the development of provincial best practices and standards for women's addiction treatment, withdrawal management, and the treatment of women with trauma and addiction. In conjunction with the Organization of American States, Robin has traveled to the Caribbean and Latin America, presenting to government, justice, law enforcement, and health officials on drug treatment courts, alternative to incarceration, partnership development, substance use, social justice, health equity, mental health, trauma, and stigma. Robin Cuff.
Hello, everyone. There's always that awkward moment where we're getting our slides sorted out. And unfortunately, I have something covering my, okay. I will get this sorted out as I'm presenting. I can't get to the slide presentation part of my menu. So thank you to my co-presenters. I think that if you don't take anything else away with you, and I hope you take more away than this, it would be to take away that we're not about fighting with each other. And I think that's really important. And I think that Jen and Carole have both presented that we come together to be client-centered, to do what is client-centered and where they are and meet clients where they are. And that is the most important thing. It's not whether we have a philosophy or a method or any of those things. It's where are people? And so if I were to change the system completely, I would be saying, to begin with, let's get rid of everything. And let's start with trauma. And I know that not everybody who has an addiction or who is part of the system is impacted by trauma, but almost everybody is. And when you add the criminal justice involvement, you realize that just about everybody is. And we have some stats on that. So if we were to redesign, I think Jen and Carole would agree, we'd start with trauma and work our way from there. But the addiction treatment system didn't start that way. And it didn't start with an understanding of trauma. So here we are, learning to embrace complexity. And trauma is complex, and so is addiction, substance use. And so are the many other factors that are overlaid onto the people that we try to serve. I like to use the analogy of the iceberg, partially because I'm from Newfoundland, so I'm very familiar with it, and partially because it just makes a lot of sense. We see so much above the surface and we make assumptions about people because of it, and trauma gets us looking beyond the surface. So, a trauma-informed approach to service. This is I want to be clear that we're not talking about trauma treatment right now. We are talking about a trauma-informed approach. Trauma and treatment is very, very important. But that's for another day. And the reason we are talking about a trauma-informed approach is that everyone can do this. Every setting, everyone can instill a trauma-informed care approach into your treatment centers, into your drug treatment court programs, into your justice programs, wherever you are, you can do this. to different degrees, but you can do this. It does take special training in order to do trauma treatment. And we have to keep that in mind. So this is one of the better descriptions of trauma-informed approach that I have come across, and it's from SAMHSA. A trauma-informed approach to services or intervention acknowledges the prevalence and impact of trauma. It attempts to create a sense of safety for participants, whether or not they have a trauma diagnosis. I'll talk about that in a little bit. Becoming trauma-informed requires re-examining policies and procedures that may result in participants feeling loss of control in specific situations. And I will tell you that trauma is so much about control and loss of control. Training staff to be welcoming and non-judgmental, and modifying physical environments. The goal is to fully engage participants by minimizing perceived threats, avoiding re-traumatization, and supporting recovery. There is often little or no cost involved in implementing trauma-informed principles, policies, and practices. And I think this is really important. We are constantly presenting the newest, best thing and the costs that are associated with it. Well, certainly we can invest a lot of money into trauma-informed care, but there are so many things we can do that cost nothing. So what are some of the trauma impacts? Well, we have people are impacted by physical abuse, they're impacted by incarceration, sexual abuse, repeated exposure, for instance, to violence, grief and loss, verbal abuse. A few weeks ago, somebody was presenting here, Nicoletta, one of the drug treatment court clients from Toronto, and she said her withdrawal from opioids was so traumatizing. And let's remember that it's about that lack of control. And often people who use substances are trying to address their trauma impacts, the things that make them feel that there's no control, the things that, and the systems that make them feel that there's no control. And they're trying to control their own emotion. So things like I've said, you know, the neglect and personal loss and torture and criminal justice involvement, confinement, imprisonment, forced institutionalization. And then there are the people who have the accidents and physical injuries and illnesses and chronic illnesses and diagnoses and medical trauma. There's the natural disasters, hate crimes, genocide, war, colonization, displacement, homelessness and displacement, and many other things can cause trauma. But you see, the last sentence I have here says, but not always. So what does that mean? Well, trauma is the sum of the event, the experience, and the effect. And what I mean is, it's the individual's experience of the event, not necessarily the events themselves. And this explains why two people can go through the same event, and one is terribly impacted and the other is not. Trauma is in the eye of the beholder. And it's important for us to remember that and not to project onto people, for instance, what we might think or what our experience would be if we had experienced the same thing. Trauma is a public health risk of major proportions. Moreover, it often compounds medical and psychological conditions and injuries. This information too often goes unrecognized or under-recognized by medical and mental health practitioners. We have a major education, prevention, and intervention issue. Christine Cordes said that at a Trauma Talks conference in 2012. One of my examples of this is in the medical field. It's not just in the addiction field. So you think of people who are afraid of dentists, and some people are just afraid of needles. But when you think about what happens in a dentist chair, you can't help but think how important it is for everyone who works in a dentist's office to be keenly aware of trauma. So the patient is lying in a chair. People around them have masks. They often are deadened. They can't talk clearly. You can't communicate very well. And people are standing over them with tools that could actually harm them. This mimics such an intense trauma experience, and often mimics things such as rape and other types of abuse. So it is not just in the addiction field or in the criminal justice field that it's important that we recognize that trauma can be pervasive, and it is important for all healthcare professionals and other helping professions to be trained in a trauma-informed approach. So what are some of the symptoms? The thing is that we can't narrow it down and say, this is a list of symptoms and this is the only list. But some of the things that are common are the panic and fear, the fight, freeze, or flight response, anger, defensiveness, agitation. On the other hand, you have the avoidance and the detachment and the self-harming activities, hypervigilance, sleeplessness and startle reflexes, intrusive experience like nightmares and flashbacks, and substance use and mental illness are also some of the results of trauma. I think what's really important as we're talking about that is to point out that we often judge people who are showing trauma symptoms. So my rule of thumb is to say that if you are dealing with a client in our field and their response to what's happening seems illogical, if it doesn't make sense, if their response, their emotional response doesn't seem in keeping with what is happening around them, then I think you are very well positioned to assume that you are dealing with a trauma response. So what about the criminal justice involved clients? I think we must assume that they are impacted by trauma. I have some statistics here among jail populations. 91% of women and 86% of men have experienced lifetime physical violence. 65% of women and 61% of men have witnessed lifetime trauma. 75% of women and 32% of men have experienced lifetime sexual trauma. And in the general population, this goes to 10.4% of women and 5% of men. I want to also qualify this because this is based on self-report. And I have always maintained that self-report, often people underreport, and also men especially will underreport things such as sexual abuse. Another study said that 48% of women and 30% of men who are incarcerated have PTSD. Now, it's higher for those who have experienced trauma and have trauma impacts. PTSD is the official diagnosis, and so there's a higher bar to officially diagnose people. So that is extremely high to have an official diagnosis of PTSD. 2/3 of women and men in substance abuse treatment report childhood physical or sexual abuse. If you work in this field or related fields, you work with people who have experienced and are experiencing trauma. So what are some of the triggers? And that's, again, very individual. But the things that we notice, the things that are very common are sounds and odors. I mean, odor is one of the biggest triggers. So somebody smells a perfume, or they smell something that is very much a similar smell, like a candle smell where they were abused. And that odor smell brings back those memories. A touch, a familiar situation, voice or tone, confinement. Those types of things are really big triggers to people, and we can't always know what is going to trigger them. It depends on the person and their experience. We cannot always anticipate it. That is why we look at trauma-informed care as a universal precaution. Let's not wait to find out if somebody is impacted by trauma or that there are triggers. Let's assume that trauma exists, because treating people through a trauma-informed lens will never harm them. But if you miss their trauma and you don't treat them through a trauma-informed lens, it actually could harm them. So why are prisons and jails particularly triggering environments? Well, they're designed with, quote, criminals or perpetrator mindset, not a victim mindset. I'm going to tell you that in my 20 plus years of working in this field, while we may have clients who have perpetrated crimes, I have not met one who wasn't a victim first. Confinement and overcrowding, a lack of privacy and lack of control and choice, and restricted movement and searches often mimic their abuse environments, and that's how prisons are designed. It's also harder to get their primary coping mechanism. So for the population that we work with, drugs are a coping mechanism. And it's harder to get that. It's not that they can't get it, but it is harder to get it. And also worker stress in these environments lead to a less than trauma-informed approach often. I'm also going to just mention briefly here that we also, it's really important for us to also recognize that some of our workers are impacted by trauma, and that the environments that they work in, such as prisons, can be very trauma-inducing for our workers as well. So I think it's self-explanatory why courtrooms and court proceedings can be particularly triggering environments. Again, there's the control, and there's the power and the authority, and courtrooms are set up to display this power and authority. One of the things in the new Toronto courthouse that we were able to do was to design a courtroom for drug treatment court that has everybody on the same level. And often when I have students who are working in or a placement in drug treatment court and they sit up at the front, I say to them, no, you're going to sit in the back with the clients in the courtroom, because that whole concept of the crown and officers of the court and the lawyers and everybody with their backs to the body of the court, I call it the wall of power. So we encourage people to get involved with the clients and sit with the clients as much as possible. So trauma-informed care. As I said, it's universal precautions applied whether or not trauma is present. It focuses on grounding and safety and soothing and strength space. This is not an approach where we say, oh, these poor people are so traumatized, we have to take care of them. We do have to provide care, but we have to partner with them. They have strengths, and we need to really recognize that and partner with them. Trauma-informed care is integrated into an organization, from the planning and program design and policies and training and infrastructure. Take a look at your program policies and see, are they consistent with trauma-informed care? And I did say that we need to be cautious about the scope of practice and special training needed if we are going to be trauma specific and do trauma therapy. But we we need training to be trauma informed, but not intensive training. Trauma responses are often misunderstood and misinterpreted, making our work less effective and sometimes even re-traumatizing. If anybody knows me, you know that I constantly talk about kicking people out or restricting service because someone displays, they show by their behavior that they need us. And then we say, oh, that behavior is inappropriate, so off you go. There's a couple of slides now about what's trauma-informed and what is not trauma-informed. I won't read it all, but I'm going to focus on the not trauma-informed section, because if we aren't educating people and our workers about trauma and impact, we are not trauma-informed. Misdiagnosis of trauma responses. So that whole, saying, oh, he's so borderline, rather than realizing that this is a trauma response that the person is showing. The tradition of toughness and reliance on heavy-handed and confrontational approaches is not trauma-informed. A closed system where advocacy is discouraged and we set ourselves up as the experts. I think Carole, and maybe Jen as well, referred to how much we learn from clients. And if we're in any environment and we have a group of people there who use substances, they know much more collectively than we could ever know. We're not the experts. A lack of understanding of trauma leads to client blaming and misinterpretation and labeling. And a lack of trauma-informed care focuses on external control and motivation, and it focuses on authority and rules and consequences rather than relationship and therapeutic rapport. Labeling, such as saying people are manipulative and needy and provocative and non-compliant. And I will say that my list goes on and on. It's one of my pet peeves that we use labeling language and it's not trauma-informed. And it is important to seek objective and neutral language. We yell at people and we issue orders and we do the tough talk and we don't provide privacy. And that is so not trauma-informed. Respectful interactions and involving client in decision-making is trauma-informed. Punishments. So imposing automatic, inflexible consequences for rule violations. And like I said, when they prove that they need our services, we then come down hard and say, you're out. Power and control residing exclusively with staff and rules and demands for compliance, rather than power and control being shared and client choice emphasized. And we often forget that trauma is a function of adaptive behaviors, and understood as survival, we will do best if we understand it as survival and strategies and resilience and a quest for safety, rather than us viewing them as intentionally self-destructive or confrontational or uncooperative or provocative. Because I work in a drug treatment court, I've often thought about how we view people. And we often develop remedies based on how we view or value the individual. And the subtext matters. So instead of offender, a client. The facts and evidence of courts, understandably, we have to have facts and evidence, but a drug treatment court brings in process and context and defining and redefining success. The safety for public, which is a big concern for, especially for Crowns. We also bring in the safety for clients. The safer they are, the safer the public is going to be. So things like trauma and harm reduction brings more safety for clients. The justice system often focuses on consistency and fairness, And I'm sure that most of you have seen, you know, the memes and everything about, you know, people on boxes trying to look over the fence. And consistency and fairness, creating a system that we think is equal is actually not equitable. As soon as we treat everybody exactly the same, then we have created an inequitable system. Focusing on external motivation rather than internal. I've already talked about therapeutic rapport. We often judge people's behavior rather than accepting their behavior as a person's best attempt in the moment. Doesn't mean they can't change, doesn't mean they can't improve, but this is their best attempt in the moment to get their needs met. And often we talk about what offenders deserve. They deserve limited opportunities, they deserve punishment, they deserve jail. And from a treatment perspective, we talk about clients deserving many opportunities. I don't put this slide up to say that we are incompatible. We are not incompatible. But when we put together things like a drug treatment court or a treatment program and a court system and a justice system, we are saying we are going to blend these models and we can come up with a much more trauma-informed approach. So if we were trauma-informed, what would be different? There would be physical environment, procedures, training, policies, language, our model, advocacy. There'd be so many differences. I have developed this slide myself because I think that the first thing I always want to start with is our language, our labels, our attitudes, and perceptions. As we talk about them, we value them. So if we allow ourselves to talk in languages, in language and words that are less than trauma informed, eventually the way we talk is how we place value on people. And as we value them, even if we say, oh, it's just words, it's just simple words, I don't mean anything by it, but the more we talk about people in a certain way, the more we value them according to that talk. And then as we value them, we treat them. As we treat them, they believe, and as they believe, they act. I want to leave some time for questions, so I'm going to leave you with this quote. And I will say that this quote is based in current and historical evidence. If you're interested, go back and look at the dodo bird effect, a study that took place decades ago. The most significant predictor of treatment success is an empathic, hopeful, continuous treatment relationship in which integrated treatment and coordination of care can take place through multiple treatment episodes. This is why in a drug treatment court, the judge's role is absolutely paramount because they are compelled under best practices to develop a therapeutic rapport, to create a therapeutic justice environment in which the client is not an afterthought. The client's needs are not afterthoughts. The client talks directly to the judge, has advocates present, and is able to express their own feelings and have interest shown in them in a justice system that, quite frankly, there is no reason for them to trust. So as Carole and Jen alluded to, we could talk on and on, but hopefully this is a primer to help us with thinking and changing our attitudes and our presentation with clients who have trauma impacts. Thank you.
Thank you very much to the three of you for speaking with us today. You absolutely have, I think, lit a fire under many of us to further our research and our understanding on these topics. We have a question from one person. This question was for Jen. Jen was wondering if there are any specific readings or resources to further the discussion about criminogenic factors as they relate to substance use.
Yeah, definitely. What I would recommend is to have a look at the programs that we utilize in Calgary Drug Treatment Court that are evidence-based programs that intervene on that type of thinking and those types of behaviors. So the two programs that we utilize is the first one is called Criminal Addictive Thinking. That is, if you look onto the Hazelton Betty Ford Foundation, will typically be able to provide more information on that. So that's a cognitive behavioral approach that really looks at criminal addictive thinking and patterns as an addiction rather than a moral issue or choice. And the second one that we use is a program that's called Moral Recognition Therapy, or MRT. You can Google that one as well. And that is a program that all of our case managers and treatment providers on the Calgary Drug Treatment team are trained in. And again, it's a cognitive behavioral treatment program that really looks to help enhance moral reasoning and decision making in terms of both addiction and criminogenic or sort of antisocial, for lack of a better term, thinking. So those are two things that I would offer as things that we do that our participants don't always want to do, but when they're finished, they say that it was incredibly helpful and meaningful to them and to their experience.
Thank you very much. And our last question is for Robin. And the question is if there's any other suggestions or ways that we can integrate trauma-informed care into all of our drug treatment courts around the province and the country.
Yeah, I have many ideas. Can I just add for a second to Jen's response? If you want to just touch on it right from the beginning, look online for the Canadian model of risk need responsivity model. That'll give you some of the basic understandings of the criminal behavior and needs and thinking, which these other things are really based on. So so how can we make drug treatment courts more trauma informed? So I think that number one, and it's really important in drug treatment courts, is to make sure that the participants, as in the justice sector and the treatment center, are trained and trained together. And that we continually come back to that. I would say debrief when difficult situations have come up that maybe didn't go as well as you wanted them to. In our pre-court meetings, the treatment people often will explain why we're presenting a certain option, or why we are maybe what may seem to be being too easy on a client. So we use those opportunities, but none of that can be effective if we keep changing the judges and the crowns and the defense attorney, or even the treatment population. It is that consistency. So when we keep changing people, they cannot be part of that culture. We create a team culture where we can disagree with each other, but we have some common understandings. So there's many other ways, the way you actually operate court, the way you refer to people, those types of things. But I think at the crux of everything is that team environment where we all have an understanding. One of the things that when I went into drug treatment court, one of the things I really noticed was that this is difficult work, and some of our treatment team were kind of seeing themselves, or being expected to see themselves, as an arm of the criminal justice system. And I said, no, you actually have to be stronger social workers, not weaker social workers. Everybody on the team has their role, and we recognize it. And then we kind of Venn diagram people in to where we come together.
Thanks very much. And we have time for one more question here. Would any three of you ladies have specific recommendations for any CAMH programs that you would recommend for individuals who are involved with the justice system and who have concurrent disorders, mental health, and substance use issues?
Well, drug treatment court does exist in CAMH, so that's one of the best. I would say, and Carole has worked at CAMH as well, so I would say that most of our drug treatment programs are fairly trauma informed and don't exclude people based on trauma or criminal involvement. I also would say that no system is perfect, and it's not always great, but yeah, I would say that most of them are fairly trauma informed. But other than drug treatment court, we don't have any specific programming for people who have criminal involvement.
Okay, and I think I'll pass it over to Justice Barnes for some closing remarks.
All right. Before we wrap up, I am just going to make reference to some of the key takeaways from each of our panelists. We tend to ask our panelists to send us their key takeaways. And so from Jen, these are the 3 points. In North America, addiction treatment is primarily centered upon the model of abstinence. This model asserts that abstinence from drugs and alcohol is essential in the treatment of addiction and long-term recovery. And then second is that abstinence in terms of addictions treatment is not simply stopping use. Interventions should focus on achieving abstinence, maintaining abstinence, modifying attitudes and beliefs related to substance use, increasing healthy life skills, addressing core issues such as trauma, and developing sustainable relapse prevention strategies. And then number 3 takeaway from Jen is abstinence-based interventions are offered across a spectrum to support recovery from addiction. Many programs utilize the concept of abstinence as the pillar of their recovery model and offer interventions that range across a broad spectrum from intensive inpatient treatment to outpatient counseling to community-based peer support and beyond. On the harm reduction, for harm reduction, Carole's 3 takeaways are as follows. 1, harm reduction is an accessible model of care that fills in the service gap in the spectrum of acuity. 2nd, harm reduction is a life-saving model of care that supports people who use drugs, regardless of where they are at in their recovery journey. And 3, harm reduction is a health equity model of care that creates and or repairs healthcare access for people living with intersecting oppressions in the social determinants of health, stigma, and racism. Robin's 3 points in regards to the trauma-informed approach are: 1, trauma-informed care, understanding trauma causes, prevalence, symptoms, and importance. Number 2, trauma-informed care is a universal precaution which is delivered to everyone, not withdrawn as punishment. And thirdly, trauma-informed care mitigates negative impacts of power structures, racial inequities, and stigma and discrimination. As we wrap up, I would just like to thank the team working behind the scenes, Kim, Andre, Jessica, Erin. Thank you very much for making this webinar go smoothly behind the scenes. And now, Jen, Carole, Robin, on behalf of everybody, this has been an absolutely amazing afternoon. You did an amazing job. Your contributions are invaluable. We thank you so very, very much for giving of your time. We are most appreciate. Thank you. To everybody, good afternoon. Have a good day. Until next time. As they say, au revoir.